what do you guys think of this here? So anyone can tell me when you see a plain film like this in any setting, somebody in on a regular floor, on a surgical floor, medical floor, emergency room, what would be your differential? What would you think about?
Yes, Prof, can I answer?
Yeah, go ahead, sure.
So I would be thinking of, it would depend on the chronicity, and that's what I would get from the history. Has this been a gradual increase in terms of abdominal distension? Because clearly the abdomen will be distended with this type of X-ray. And
what do you see on this plain film? Hello? Hello? Hello?
No. Hello, Assalamu alaikum, Prof.
Assalamu alaikum. Okay, what do you see on this plain film?
Prof, is not clear for me. Like, it's important to differentiate whether it is small or large bowel.
Okay. What do you think it is, at least in part? Do you see some large bowel?
I don't think so.
You think this is all small bowel?
No, it's a combined. There is a lateral dilatation. According to the site, there is a large bowel on the right side of the picture, on the splenic flexure, with a cutoff sign, air fluid level.
Okay.
It's a gross distension.
You think there's some large bowel dilation, right?
Yeah.
Okay. So what comes to your head? So what's the differential?
Large bowel, according to the age of the patient, it may give me a clue about the cause. It could be malignancy.
Okay, so it could be. So okay, we just want to know. We just want to know about titles. You think colon cancer, right? Or rectal cancer,
yeah.
right? Okay.
Yeah.
What else? What else?
The sigmoid volvulus could be one of the causes.
Okay, volvulus. What else?
It could be fecal impaction only.
Okay. What else?
The complicated diverticular disease.
Okay, excellent. Okay, these are 3 causes. Okay, anything else?
Maybe air under the diaphragm will give me a clue about is it perforated or no?
No, we're just asking about what causes this colon to dilate. So you mentioned 3 important ones, and probably the only ones, honestly. Colon cancer and rectal cancer. That's number 1. Number 2 is complicated sigmoid diverticular disease. That's number 2. Number 3 is volvulus. What you're talking about here, obviously, is mechanical obstruction, right?
Yeah.
Okay. Could that be anything else other than mechanical obstruction?
Yeah, it could be paralytic ileus or toxic megacolon.
Paralytic ileus.
Could be pseudo-obstructive.
Pseudo-obstruction, right?
Yeah.
Pseudo-obstruction. Okay. So it could be mechanical obstruction or it could be pseudo-obstruction, right?
Yeah.
Right. So what would be your what would you do when you see this? What would be your next step?
The next step is to put NG tube, make the patient MBO, NG tube, catheterization, I'll give IV fluids for resuscitation. Prepare blood for this patient, probably. Monitor input and output chart. Giving antibiotics. Then, according to the status of the patient, is it if he is hemodynamically stable or not?
Okay, what is your plan? What's your plan?
This patient probably he needs surgery. Yeah.
You're gonna operate?
If the cause is obvious.
You go into the operating room?
Yeah.
You to do what? What you gonna do in the operating room?
According to the cause. If it's left side colonic tumor, maybe the patient is unstable, old age, I will do minimum to defunction, to press the bowel. Then for workup, post-operative, after he becomes stable, to stage the disease. Then to prepare him for definitive procedure.
If that was valvulus, you're gonna operate?
Volvulus, we have non-operative techniques that we can do.
But you're telling me you go into the operating room, right?
If it's malignant, I told you according to the cause.
We don't really know this. All we have in guys now is a plain film, right? That's what you have here. And we asked you, he said IV fluids, Foley catheter, he said NG tube, antibiotics, fluids, all this is fine. And he said you go into the operating room, correct, Muhammad, right?
Yeah.
Okay. So my question to you, if this is valvulus, are you going to the operating room? You just told me you're going to the operating room, right?
No, if it's valvulus, there is non-operative technique that I can try.
How do you know, Muhammad? How do you know it's valvulus? How do you know?
There is sign on X-ray, coffee bean appearance, that may give me clue.
This X-ray, look at this X-ray. Are you taking this patient to the operating room? Does everyone agree, guys, that we're taking this patient to the operating room?
It depends on the general condition of the patient after I took a good history and I do thorough examination.
Okay, is there any chance that this patient is not going to the operating room?
Hi, Prof. Can I answer?
Yeah, please, anyone. Yes.
So I think we need to look for the causes before taking the patient to theater. So after
I'm sorry, how is this Mazen?
Mazen, yeah, from Cape Town.
So Mazen, are you one of our registrars, senior registrars?
Cape Town. Yes, I am from Cape Town, South Africa.
One of our registrars?
Yes, one of the registrars.
Okay, so Mazen, so tell me, he's saying that we're gonna sit down, relax, think about things, and find out exactly what we're dealing with. Is that what you're saying?
Yes.
Good. So the point number one, guys, that we need to talk about here, we learn, is when we see this plain film, we know it doesn't mean that we're going to the operating room. We may, but we don't know. I honestly have no idea what this X-ray is and what's causing all this. To go to the operating room unprepared rather, not knowing what's causing all this can be really a big problem. So Mazen, go ahead and tell me, what would you do?
Okay, so first I would start with the history, asking about the duration and any history of weight loss, any previous pathology before, and if this happened before or not, and any previous surgery or not. And in the examination, I need to examine the abdomen, check the hernia orifice, and make sure the patient is not peritonitic. Then I will do PR, check if there is mass, if there is bleeding, if there is impacted stool or not. And then after that, if the patient is not peritonitic, I will send the patient for CT scan.
Okay, so Mazen, if I give you only one test, you only allowed one test to do for this patient to help you decide what you should be doing, what would that test be? You only allowed one test.
CT scan, contrasted CT scan.
What kind of contrast CT scan?
So oral and IV CT scan.
Oral and IV CT scan.
Yes.
Anybody listening to us would order anything different. You only allowed, if I allow you one test, nothing else, what would you order?
Sigmoidoscopy or colonoscopy after PR.
So you would do colonoscopy, yeah? Okay. Anybody else, guys? You only allowed one test. Anyone?
If the patient creatinine is high and we are worrying about his kidney function, we can do contrast meal and follow through.
Contrast what, sorry?
Meal and follow through.
You mean oral contrast?
Yes, and follow through, and then take serial images after that.
Okay. Anybody would order anything else or any different type of a scan? Anyone? Okay. So I have, if I was me, I was going to order one single test, and that would be a CT with rectal contrast. What do you think, guys? Is that reasonable?
Yeah.
If I can give IV, I'll give IV and rectal. I wouldn't give oral. So Muhammad Ali, CT with IV and rectal contrast in this case, okay? Can you tell me how that would help? Why would I order this? Mazen, why would I order a CT scan with rectal contrast only or rectal and IV? Why? What would that tell me and how would that help me?
So the rectal contrast will help you if there is a rectal lesion or lower colon lesion, like sigmoid lesion or something like that, to see the whole large bowel from down up.
Now, what's the first question that the CT with rectal contrast is going to answer for me, which is
The level of lesion.
Is it complete obstruction or not?
That's second question. That's the second question. What's the first question?
Can show any perforation, retroperitoneal from the left colon.
What did we say that could be? Could be obstruction or what?
Pseudo-obstruction.
Pseudo-obstruction. So the first and the most important question that the CT with rectal contrast is going to give you the answer for immediately, is that obstruction or not? You're going to inject rectal contrast in that. It's going to go straight to the cecum. No mechanical obstruction. Totally different disease. Totally different management. In fact, it's such a different management that if I make the mistake of not knowing this and taking somebody with colonic pseudo-obstruction straight to the operating room, I'm causing this patient a lot of harm. A lot of harm. Because there are so many things that should be done, and the last of them and the least helpful is going to the operating room. So the first question that this CT with rectal contrast or gastrographic enema if you want, water-soluble enema, that's fine, but CT is better, and we'll see why. The first question that this is going to answer for you, is that an obstructed colon or not? The second question is, if it is obstructed, is it complete or partial? The third question, if it is obstructed, where? Is it sigmoid, splenic flexure? And the third question is, possibly, is if this is cancer, is it advanced cancer? Can I see liver mets? Do I see ascites? This is how much information a single test, CT with rectal contrast, is going to give you. And if it's obstructed sigmoid, is it volvulus or complicated diverticular disease or upper core lesion cancer? All these answers you can have with one single test. And it's going to guide a lot of things, as we'll see in the management. One person without any obstruction, colonic pseudo-obstruction, no mechanical, is going to go to the intensive care unit. He's going to get his fluids adjusted. He may get nystagmine to decompress that. He's going to feel better, hopefully in a couple of days, and we're going to avoid surgery. The guy with the volvulus is going to get decompression from below with flexible sig and maybe a rectal tube, then an operation later on. The guy with the upper core lesion, if it's not complete obstruction, maybe I have time to do other things, clean the bowel, so I can do a better operation. And the guy with complete obstruction, whether diverticular disease or sigmoid cancer, complete, doesn't go anywhere else, the contrast. This person actually is probably getting an operation in the next couple of hours after some physiologic adjustment. So there is a lot of information that you need when you see this plain film. And this is what we tell our people, our trainees. When you see this plain film and the dictum, the aphorism is, anybody with dilated colon on a plain film needs some kind of contrast study from the rectum, so you know what you're dealing with. And you know something? Oftentimes the nature of patient that you're dealing with will give you an idea what possibly could be the etiology of this. Before we start doing this, let's ask a few questions. Mazen, who would get colonic pseudo-obstruction? Can you describe to me the circumstances and the patient who's gonna get colonic pseudo-obstruction? What kind of circumstances? What kind of patient?
Old patient, institutionalized patients, and patient with bedridden usually.
I'm sorry, say this again.
Old patient institutionalized in institution for a long time, patient are bedridden, and patient are using chronic, they have like chronic use of enema.
Okay, so everybody stay with me for a second. What Mazen described, I'm gonna repeat what he said. We asked which patient and what circumstances we have colonic pseudo-obstruction. Colonic pseudo-obstruction. He said it's a bedridden, older patient in institution who's using maybe lots of narcotics. Do you guys agree? One moment. Do you guys agree that this is the patient who gets a colonic pseudo-obstruction?
I think, Prof, the general concept about the pseudo-obstruction, is it primary or secondary chronic? pseudo-obstruction. And usually the primary is due to failure of the muscle to propagate or to propel the
Mohammed, I'm just asking, just give me the patient first. You are in the hospital working. Can you tell me who and where and what circumstances you are going to see a patient with colonic pseudo-obstruction? Ogilvy's. Ogilvy's.
Yeah. I think all patients with electrolyte disturbances.
Why is he in the hospital?
Dialysis, maybe.
Anybody else, guys? Anybody would tell me who is the classic, typical patient that we will see as surgeons and get consulted to see who has Ogilvy's, colonic pseudo-obstruction?
Neglected elderly patient.
Why is he in the hospital?
I think they generally happen with patients with chronic heart failure and chronic renal failure. And they're being treated for that.
So more typically, guys, the typical patients, and believe me, with this presentation, this X-ray here, you'll see that different patient in different circumstances with different demographic features can give us a lot of clues to what's causing this. Ogilvy's syndrome, colonic pseudo-obstruction, classically, it's an acute problem seen in a patient with an acute physiologic issues, most commonly a recent operation involving trauma, joint surgery, spine surgery. This is the most common presentation, or cardiac operation. Typically, it happens 5 to 6 days after the operation, CABG, coronary artery bypass, acute pancreatitis, hip fracture, hip replacement, spine fusion. 5 or 6 days later, cold general surgery, the abdomen is distended, the patient is not having bowel movement. This is chronic pseudo-obstruction, Ogilvy's. Mazen described a different patient. A patient was taking narcotics in institution, elderly, bedridden. And I may add to that one more thing. Taking psychiatric medications. What does this patient have? What's the diagnosis? Is it Ogilvy's? Is it Ogilvy's, guys?
We can apply it for valvulus as well.
Maybe valvulus, but it can lead to valvulus. But what's the underlying problem? It has a name. And it's a chronic condition. Colonic inertia. 2 different patients, guys, with this picture. One, joint replacement 5 or 6 days ago, acute problem, didn't have a problem before, or a spine fusion after trauma or spinal fracture. Dilated colon, no bowel movement, 5 or 6 days abdominal distension. That's one patient. The other patient in a psychiatric ward or floor or bedridden or paraplegic for the last 5 or 6, 7, 8 years, taking narcotics, taking psychiatric medications, coming to the ER, abdominal distension, with history of repeated similar presentation for the last 3 or 4 years and hospitalization. Getting an X-ray like this, you log into the system, you see that he's been having that for years. colonic inertia. Totally different disease. Totally different disease. Right. Still going with the type of patient that we're going to see this problem in. Volvulus. What kind of colonic volvulus do we have, guys? And I can think of two types. What are they?
Sigmoid and cecal volvulus.
Excellent. Can you describe the sigmoid? Are these similar patients? Can you describe the sigmoid patient for me? Sigmoid volvulus patient, can you describe him or her? And where do you see them? And what setting? Anyone, guys? Is it the same like cecal volvulus? Anyone?
I think, Prof, sigmoid volvulus can happen in depending on the age. Young patients or old patients, the presentation is different.
Most commonly.
Most commonly is acute in the young patients or patients with I think in older patients.
I tell you, Muhammad, I've been doing that for 30 years plus. I've not seen one single sigmoid volvulus in a young patient. So elderly patient, right? Nursing home or bedridden at home, presenting with the dementia, Alzheimer, coming in, brought in by the family or the caregiver, saying, this patient who's 85 or 90 years old or something, his abdomen has been distended, he hasn't had a bowel movement for 2 or 3 days. And when he asked them, they say, yes, we were in the hospital a year ago and had a similar problem. They did something and he went home. And now he's coming with this problem. Abdomen grossly distended. Okay. You get a plain film, you see hugely dilated colon, minus plus this, coffee bean, whatever, okay? Who can describe to me the patient with cecal volvulus?
Can I try to add something? So here in Cape Town, we see sigmoid volvulus in young Black patient as well. It is more common in older patient, institutionalized patient with a neurological problem, neuromuscular problem, as you said, but we see them in young Black people as well. But regarding the cecal volvulus, we have two types. We have the axial and we have the pascule, which is less common, it's about 20%. And we see them in young patient usually. Due to congenital malformation, the cecum is freely mobile.
Younger, right? What gender?
Female more.
Okay, excellent. What's the presentation?
So they usually present with either small bowel obstruction or right iliac fossa pain like appendicitis.
Excellent, excellent. So they can present with a small bowel obstruction, absolutely, because the cecum is volvulized. Perfect. Do you get any previous history of similar episodes?
Yes.
No. Not like sigmoid. Sigmoid, you can get previous history. This one here, it's an acute presentation. Can you tell me how the management difference between sigmoid and cecum?
So sigmoid, we can start with the deflation first with the rigid sigmoidoscopy, and then after 3 to 4 days after that deflation or after that sigmoidoscopy, we give time for the bowel to settle, we give time to edema to settle, and then we need to do the operation for this patient.
What operation? So
do sigmoidectomy.
Do you do operation the same admission or you bring him back?
No, we keep him in the hospital for 3 to 5 days, and then we do sigmoid elective or semi-elective sigmoidectomy.
Why can't you just let them go and bring him back?
Because we deflate the sigmoid, there is a risk of perforation. We need to keep an eye on the patient, and there is a high risk of recurrence. It's about 50 to 60% recurrence within days. So that's
the second reason number 2 is the main one.
Yes.
Recurrence. Okay. You said you're gonna decompress that and operate in 3 or 4 days, which is good. I agree. Can you tell me the circumstances when you're gonna operate on acute sigmoid volvulus right away? What would make you operate?
If it is there is perforation.
Okay.
If in the rigid sigmoidoscope we see necrosis, black mucosa, then we need to operate. If the patient is peritonitic, we need to operate.
There's one more reason, right? If you can't detorse it, right?
Yeah, you cannot detort it, yeah.
Excellent, excellent. So sigmoid volvulus, we make the diagnosis, we detorse it as long as the patient is not acutely ill and it hasn't perforated. And the only time we operate right away if the patient is perforated or I see necrotic mucosa on endoscopy, or I cannot detorse it. Right. You said you're going to operate in 3 or 4 days, right, Mazen?
Yes.
What you going to do in these 3 or 4 days? What are you going to do with the patient?
So some institution put rectal tube after the deflation, but we do not do that in our institution.
I don't do that either, okay?
Mm-hmm. So we just keep giving the patient IV fluid and some laxative, and that's it. Try to optimize the patient. If he is like having a problem with nutrition, then we need to support him because we might do intestinal anastomosis. Try to optimize the patient for the operation, basically.
Okay, do you give them bowel prep?
No.
You don't prep the colon?
No, because after the deflation or detorsion, most of the bowel is going to be a runny stool and it will be clean on the left side.
Okay, I'm not sure about that, but do you do anything else?
As I said, optimize the patient, correct his electrolyte, give him fluids. That's it, basically.
Okay. And how do you know that he doesn't have cancer?
So, depending on the presentation of the patient, if I don't think we saw, I don't know if it's going to happen, sigmoid volvulus with cancer in the same setting.
No, how do you know that it doesn't have cancer in the right colon?
After the operation, we can do colonoscopy after that.
After you operate?
Yeah, 4 to 6 weeks after the operation, we can bring the patient back to do colonoscopy.
And if you found cancer, you're going to give him a second operation?
As I said, that is not the usual case, but we can do tumor marker if we are concerned, or even if we are not agree with the diagnosis, we can do CT scan.
Okay. Usually we keep those people for 3 or 4 or 5 days, as you said, get them optimized, clean the bowel, do a full colonoscopy to examine the entire colon, and then operate.
Okay.
What operation do you do?
Sigmoidectomy.
Okay. Do you do primary anastomosis or colostomy?
So again, depend on the situation of the bowel itself, but we usually do primary anastomosis. We try to opt for primary anastomosis.
Okay. Say the bowel is okay, you're going to do primary anastomosis?
Yes.
Okay. And you do that on all patients? So the patient, what's the typical patient again, he said? Demented, bedridden, you're going to give
Yes.
this patient, you're going to give him an anastomosis.
So they are saying we see the patient, if they can tolerate the leak, then we do primary anastomosis. If they can't, we bring a stoma.
It's not a leak, Muhammad. It's not a leak. It's not a leak.
If they can tolerate, a leak, so we do primary.
I'm not worried about the leak. There are two critical things you must have before you give somebody a colorectal anastomosis or ileorectal anastomosis.
Sphincter,
Number
we need
one,
to make sure sphincter is intact.
the
and
sphincter is
continence.
intact and the patient is ambulating, can go to the bathroom, can hold the bowel movement till they go to the bathroom, or at least say he's going to have a bowel movement till somebody sit him on a commode. You are dealing for the most part with a nursing home or somebody bedridden, demented, in diapers, incontinent. You are going to give this person anastomosis?
So if they are incontinent, I'm going to do colostomy for
Well,
them.
that's why we're asking you, are you going to give everybody an anastomosis? So the answer is no, I'm not going to give everybody an anastomosis. I'm going to see who my patient is. I'm going to ask two critical questions. Has this patient been continent before all this happened or not? Has this patient been ambulating? Can he go and sit on the toilet, hold his bowel movement? Or if he can't, and for the most part, with these patients, absolutely. For the most part, they're not continent, they're not ambulating. These are most of the time elderly patients who are bedridden. Some of them are sitting in a pool of stool before coming in. The best thing to happen.
Can I interrupt you? Because we, as I said, we are seeing younger patients with this problem. That's why we opt for primary anastomosis.
Okay.
Most of our patients with sigmoid, we have black young people.
Right. Younger patients are different.
Yes.
This is a special situation you have. The situation in the entire world, almost. Sigmoid volvulus is a disease of elderly patients with issues. And most of them are demented, bedridden, dependent on others for care. Do you agree?
Yes, definitely.
Okay. How different is management of cecal volvulus?
So cecal volvulus, we need to resect. We cannot do detortion. So we need either to do ileocecectomy or right hemicolectomy.
All right. Perfect. Right colectomy with ileocecal anastomosis, with ileotransverse anastomosis. We talked about colonic inertia and we said this is different from Ogilvy's. How different?
What do you mean? I didn't understand exactly.
How different is the management of Ogilvy's from colonic inertia?
So Ogilvy's, we, as you said, we need sometimes to do a colonoscopy to deflate the colon. We sometimes give new stigment that will help, but we need to take care of the patient, put them on the monitor because of risk of bradycardia. And they usually settle with this management. But in inertia, we need aggressive. Sometimes they will end up with total colectomy in advanced cases if they are not responding to like laxative and biofeedback and things like that.
Absolutely. You're absolutely right. The management of Ogilvy's for the majority of time, in most instances, is non-operative. In fact, you should probably try and avoid any operation on those people. However, chronic inertia, this is a chronic problem. You very likely, after proper workup, after properly working up this case, you will need to do a total abdominal colectomy and probably ileorectal anastomosis.
Can I comment, Prof, on this sigmoid volvulus
Sure.
I think I agree that sigmoid volvulus usually occur in younger patients, usually middle age. I think the last series we had, I think around 50 patients. That was a thesis by Dr. Mahmoud Abdelbadi, the vascular surgeon so far. And the majority of these patients are between 40s, and they are usually coming from the countryside. And we keep them actually because if you deflate them and they feel well, they won't come back. And we had actually in that series 2 or 3 patients who had deflation and they disappeared and they came with gangrenous bowel. So usually the trend is to keep them in hospital until you do the resection and anastomosis.
Right, absolutely. We never really send them home at all.
Yeah,
because it recurs all the time.
That's right. Yeah.
So Mazen will stay with you for the cancer, malignant obstruction,
Yes.
right? So fundamentally, is there a difference between obstructing sigmoid cancer and obstructing rectal cancer?
Yes, of course, the management is different. So in sigmoid cancer, we opt to do the surgery first, and then we can assist the need of adjuvant therapy after that. But in the rectal cancer, there is a possibility of new adjuvant chemoradiotherapy. So if the patient obstructed, we usually do loop colostomy, and then we do new adjuvant chemoradiotherapy, and then we do the operation.
So
if they are fit for that.
Okay, so everybody who's online, guys, with us here and heard what Mazen said, it's probably the most important thing that you can get probably out of the topic of malignant obstruction of the colorectum. What he just said is probably the most important thing that the message you need to take home when you're dealing with obstructing colorectal cancer. Colorectal. Rectal cancer, it's a totally different disease. When it happens in the mid and lower rectum, we do not do a primary resection. We do not do a primary resection. We do diversion, and we're going to talk to Mazen in a second here about what he said colostomy, but we're going to discuss that in a second. But we're going to do diversion. Obstructing mid and lower rectum, presenting with obstruction, please do not do APR, abdominal perineal resection, or LAR, low anterior resection, acutely on an obstructing mid or low rectal cancer. These individuals, by definition, they have locally advanced rectal cancer, and the standard of care for these individuals is neoadjuvant chemoradiation and then surgery. On the other hand, obstructing upper rectal cancer in the upper third, or rectosigmoid, or sigmoid, these are treated like colon cancer. And as we all know, we don't have neoadjuvant treatment for colon cancer. And I'm talking neoadjuvant treatment for colon cancer, not metastasizing to the liver. That's a different story. I'm talking locally advanced rectal cancer without liver mets. We don't have neoadjuvant. We do primary surgery if they are obstructing or bleeding. Those individuals, we go ahead and operate. And then after that, fine, they get adjuvant treatment. The question is going to be to Mazen in 2 areas. Number 1, let's start with the easy one. Obstructing sigmoid cancer, Mazen, okay?
Yeah.
We're going to operate, correct?
Yes.
Okay. Can you give me the surgical options that you can offer the patient who has obstructing sigmoid cancer? Operative options, procedures, operation.
Yeah, so the first price will be sigmoidectomy, and then either with end colostomy, or if the situation of the patient clinically is stable, he's not in adrenaline, he's not sepsis, and there is no fecal contamination, I will do colorectal anastomosis.
Okay, so first option is sigmoid colectomy minus plus anastomosis, correct?
Yes.
Good. Any other options?
Hartmann procedure.
Oh, that's
Then-
sigmoid colectomy minus plus anastomosis, right?
Yes.
Okay.
And we
Any other options?
can do stenting as well to try to optimize the patient for surgery.
Okay.
That's good for the left side cancer, colon cancer in general.
Okay. Any other options?
If we can take the cancer out, we need to do sigmoidectomy. That's the bottom line.
Okay. Any other operation?
I'm not aware of.
Okay. So let me ask you a question. What problems you may have if you do a sigmoid colectomy on those people with or without primary anastomosis? What potential problem you may have in the future? Oh, let me reverse that a little bit. What operation, what circumstance that you cannot do just sigmoid colectomy in these patients and you have to do more?
So if it is a higher sigmoid, then we're gonna do a extended left or left colectomy. It's better because of the shed area between the sigmoid and colon or the splenic flexure as well.
Okay, let me ask you a question, Mazen. What if I tell you that my preferred operation in this case, just hypothetically, is total abdominal colectomy and iliorectal anastomosis? What would you say?
So I know that there is synchronous lesion, like 20 or 30%. There will be a synchronous lesion in the other part of the colon.
So number one reason you're gonna tell me, yeah, I understand why you're doing this because you're worried about synchronous lesion, okay? That's number one reason. So I have a reason, I have a rationale to give you. Okay, good. Is there any, I can think of two other reasons.
Familial FAB, if the patient with the FAB and discovered with sigmoid cancer, there is a risk of the other colon be
maybe
having another cancer.
No,
And
we're talking sporadic cancer, it's okay, yeah.
And if the patient have cancer with known ulcerative colitis as well.
No, it's okay. Let's just say none of these. I can think of two other reasons and at least one circumstance where I'm going to come to you and I say, I did total abdominal colectomy and iliorectal anastomosis because of this.
Cecal perforation.
Thank you. Splitting of the cecum and almost perforated or perforated already. He's getting a total abdominal colectomy, iliorectal anastomosis. What other reason that I may give you that I'm going to do iliorectal, total abdominal colectomy and iliorectal anastomosis? What if I believe that I never do a colonic anastomosis without mechanical bowel prep? There's a school like this, right?
Yes.
Okay, this patient is not prepped, right?
Mm-hmm.
So if I want to avoid a stoma and at the same time I avoided a colostomy, say I am a surgeon that my philosophy is never to do colonic or colorectal anastomosis without a bowel prep. Some people, lots of surgeons, in fact, the majority of surgeons probably I know believe in this, okay? Yes. I know that the literature says you can do it, but especially on the oral board here in the United States, you'd better tell them that I need a bowel prep before I do an anastomosis, right? So let's say that I'm not going to do colorectal anastomosis without bowel prep. And the patient doesn't want me to do a colostomy. I have an option for him. Unfortunately, I have to take his entire colon. But I'll give him total abdominal colectomy with iliorectal anastomosis. I killed 3 birds with 1 stone.
Once.
Number 1, I got rid of any potential synchronous lesions on the right side. Number 2, I didn't give the guy a colostomy. Number 3, I didn't worry about bowel prep. Some literature actually, in the American Journal of Surgery and other places, a lot of people prefer actually this option for left-sided colonic cancer lesion. To do this. Okay, let's leave this alone.
Can you do on table bowel prep?
Absolutely, but it's kind of really hard and tedious, and
Yeah.
the circulating nurse doesn't like you, and they start screaming, and you get a lot of stool on the floor and all this. It's a very tedious operation. So, but definitely you can do this. So back to you, Mazen. Rectal cancer. You told me mid and lower rectum. It's a different disease. We're not doing a primary resection, correct?
Yes.
Excellent. That's great. You're going to divert, right?
Yes.
Okay. What
We
kind
usually
of
do a loop colostomy, sigmoid colostomy, loop.
You're going to do a loop sigmoid colostomy.
Yes, if they are obstructed.
Okay.
If not, we can send them, if they are T2 or more, we
No,
can
we're
send
talking,
them.
we're talking today, we're talking obstructed rectal cancer. Stay with me.
Okay, so sigmoid loop colostomy.
Okay. What operation are you going to do in the future on this patient?
So depend on the response of radiochemotherapy. So depend on the level of the lesion and depend on the anal sphincter.
Well,
as
there are
well.
only 2 operations that you're going to do. What are they?
Yes, so either low ABR, low anterior resection with TME, or we're going to do ABR. So as I said, depend on the level of the lesion and depend on the anal sphincter. Is it involved or not?
I agree. Good. How are you going to do a low anterior resection 3 months or so after you've already done loop sigmoid colostomy? Can you tell me technically how?
What we usually
Honestly,
do.
I don't know how.
Yes. What we usually do, we take the sigmoid colostomy down, we suture it closed, and then we do our regular lower anterior resection. We usually, in this case, we do it open, not laparoscopic.
So you're going to close the colostomy, correct?
Laparotomy, we're going to take the colostomy out, we're going to close that stoma that we did, and then we proceed with the lower anterior section.
But you have 2 staple lines, correct?
Yes.
You do, right?
Yes.
And what did you give the patient before you did this operation? What did the patient have in the last 3 months?
Radiotherapy.
Radiation, right?
Radiotherapy with the chemosensitization.
Okay. And you do primary anastomosis unprotected in these instances, right?
We do, if we're going to do primary anastomosis, we usually do covering ileostomy for them.
So let me see what we just did. We took a colostomy down and we have a staple line that can potentially leak. Then we went down.
No, we're going to take the stable line with the specimen.
And you're going to resect the sigmoid distally?
So if we're going to do lower anterior section, we're going to take the sigmoid and the rectum as well. So we keep the colostomy with the specimen that we need to take out. No, we don't keep it in the patient.
So you are going to resect from the loop colostomy site all the way down to the low rectum.
Yes. That's why we usually opt for low sigmoid near to the colon as much as near to the rectum as much as we can. That's why we take the loop. That's where we take the loop colostomy there.
What if it doesn't reach? We're talking now in left colon? What if it doesn't reach in the low rectum? I just want to remind you, you have a mid or low rectal lesion here. What if it doesn't reach?
Prof, in my short time that I did in colorectal, we didn't see any kind of this patient, but I know there is option we can do loop ileostomy from the beginning.
I have a better option for you. I don't think you've seen it, because I think what you're describing is not really possible to do with ease, and it's a problem. So, but I have a better solution for you, and that is the answer of the fecal diversion when this guy came as an emergency. The answer is, well, what kind of fecal diversion you're gonna do? You should answer me with one thing. You say, it depends where the lesion is. If I'm doing rectal exam and I find the tumor right there in the low rectum, I know for sure I'm doing an APR in 3 months after neoadjuvant chemoradiation. This person is getting a loop sigmoid colostomy. Do you know why? Because 3 months later, I'm gonna do what you just told me. I'm taking this whole thing and the anus and the anal canal, and I already done half of the operation. He already has a colostomy. It's perfect. However, if I'm doing rectal exam and I can feel the lesion, and there's a good chance this is a high enough lesion that is gonna get low anterior resection, and I'm gonna preserve the anal canal and the rectum, this person, when he comes to the emergency room, is getting a loop ileostomy, not a loop colostomy. And you know why? Because 3 months after neoadjuvant chemoradiation, I'm gonna go and do a low, in a virgin left side and virgin pelvis, I'm gonna do a low anterior resection, I do a primary anastomosis. I'm not gonna touch the loop ileostomy that I did 3 months ago, because he needs it to protect his radiated anastomosis in the pelvis until I secure the healing of this anastomosis. Then he's gonna probably get adjuvant chemotherapy anyway. I'll let him finish all this, and I'm gonna go back, do a gastrograph and enema or rectal contrast, it doesn't matter. Check my anastomosis, nice, healed, no leak, no structure. Guess what? Then, which is actually about 5 months after the time, since the time he came to the emergency room, I'm gonna go and get rid of that loop ileostomy. So it depends. Do you see how obstructing rectal cancer is totally different?
Can I ask
Totally
a
different from
question,
all.
Prof?
Yeah.
So what will happen with the colon content? So we did loop ileostomy, but the colon is full with feces because of obstruction. You're gonna leave it there.
Yeah, I mean, you can do if you wanna do a loop ileostomy and mucus fistula. Some people do mucus fistula or something, but we never had any problem. Fine, yeah, you leave it. So it's what's gonna happen to it. So really, if you want to decompress it, or something, you can decompress the cecum, and that will decompress the colon. If the ileocecal valve is incompetent, you're gonna be fine. It's gonna decompress that. So it shouldn't be an issue actually. So.
Okay.
Prof,
Yeah.
I just want to add on our local practice here. I've been working with a colorectal surgeon for a long time. What he did in his policy, transverse colostomy, loop colostomy first, can solve the problem because of we don't have here really a colostomy care nurse to take care of ileostomy, because ileostomy has major problems, electrolyte disturbance, and you need to follow up the patient more. Transverse colostomy will solve the problem, either for the low anterior resection, ultra low. If you want to mobilize more up to splenic flexure, it can give you a chance. It can solve also the bowel preparation through it. You can do it.
Yeah. So
Well, what do you think of that?
yeah, definitely. Some people would do a loop transverse colostomy, but it's not really. It's a very bad location to put the colostomy in, and if you are doing a midline after that, you're going to have a problem where you situated this transverse colostomy. Transverse colostomy is not really a preferred site to put a stoma in the abdominal wall. So, and you know, but you're right. Some people do this, but it's probably not a preferred site to do that. But if the local thing, and you're worried about the electrolytes problems and all this with the ileostomy, I guess I have to respect that. But if you guys go to the literature of the colorectal literature, I think everybody would agree that when you're doing a low anterior section after chemoradiation, the discussion is always loop ileostomy or not, right? I think you all agree that this is the standard. And loop ileostomy, it's easier to close. You don't need another laparotomy to close it. It's located in a proper area where you can close it without having to do a laparotomy, as opposed to a transverse, as opposed to transverse colostomy. So, so I have a few slides, guys. You want to go over the slides?
Sure, sir.
Okay. All right. Let's see what the slides show. And I'm going to try and make it quick. So let's see. So one of the good places, guys, to find a good read about that, this is an old book, but there are new editions of that. The 17th edition just came out. It has really good discussion about all this. And we know the difference between small bowel obstruction and large bowel obstruction. Everybody talks about small bowel obstruction, and we often tend to operate quicker. To be honest with you, large bowel obstruction is the more dangerous than small bowel obstruction. And the reason for that is you have the cecum. And if the cecum perforates, you really have a problem. So as we tell our trainees, if you see a large bowel obstruction, this is the one that should get you out of bed and have you operate in the middle of the night as opposed to the small bowel obstruction. Why is that? Is two stories here. I was in Walsgrave Hospital, I remember very well, in England. And we had this lady who was in the hospital, had colonic dilation, and we kept saying, let's get some CT with rectal contrast. She said, no, it's just ogilvies. Sure enough, a day or two later, she coded and she had an apple core lesion, to show you how important it is to get CT with rectal contrast. Another patient in England several years ago had a cabbage. And again, we saw that plain film and we said, oh my God, this is large bowel obstruction. Took the patient to the operating room. Sure enough, it was ogilvies. He never needed an operation. How could we have avoided this? How could we have avoided this? Again, CT with rectal contrast. We never needed to do this operation 5 or 6 days after a cabbage, and we were never able to close the abdomen because the colon is so distant. Another one in the United States, cecal volvulus, plain film, no rectal contrast requested. The lady coded 12 hours later with dead cecum because we did not get a CT with rectal contrast to make the diagnosis. Just 3 examples to show you how important it is to make this diagnosis. So ask yourself and think about key issues, and then have an algorithm when you see that plain film we just showed. The first question, is the colon obstructed or just dilated? If the obstruction, is the obstruction complete or partial? So do I have time to do things if it's partial? Is the obstruction proximal or distal? Big difference. Is the obstruction due to cancer in the lower 2/3 of the rectum, like Mazen just mentioned? Obstructing cancer in the lower 2/3 of the rectum, mid and lower rectum. It's a different disease, guys. Do not resect these as an emergency. That's why we underlined this slide. It's really important. Is the patient too sick and I should do a damage control operation, just like we talked about colonic perforation? Remember last week? Damage control. All these questions should come into your mind. Definitive anatomic things should not be done in the middle of the night. Resect the obstruction, but don't close the abdomen. Don't do an anastomosis. You don't have to do all this. I can always resect and anastomose the right colon, but there is a distal obstruction to my anastomosis on the left side. Always remember that. We always think that right colon you can resect and do a primary anastomosis, but think, do I have obstruction distally that I should worry about? And you can get this answer with rectal contrast. Do you see how many answers, guys, CT with rectal contrast provided you? So many, regardless of the cause of obstruction, the degree of obstruction, proximal, distal, right versus left. Huge light coming up to help you how you diagnose these. Don't work in the dark. There is one test you're allowed to get in this instance when you see a plain film of dilated colon. One test, it's a rectal contrast study. If you say I don't have CT with rectal contrast, I don't have the facility to do this, fine. Get a gastrographin element, preferred gastrographin. Barium, if you're not worried about perforation, get barium. Get something. It's gonna help you avoid a lot of error. I can always do a primary anastomosis in the colon emergency, but does this patient walk and is continent? We talked about Mazen patient. Yes, I can do a primary anastomosis, but I have to know if this patient can walk, go to the bathroom, and he can hold the bowel movement. Do not do primary anastomosis, guys, on somebody who's fecal incontinent. It's a big problem. In case of left side obstruction, how much should I worry about proximal synchronous cancer because the patient never had a colonoscopy? Typically, if we here in the United States, if I see 10 patients with obstructing rectal or sigmoid cancer, at least 9 out of them never seen a doctor and never had a colonoscopy. How do I know that there is no cancer in the transverse of the right colon? I don't. Think about it, okay? Are stents great and can Mazen mention stents? Yes. Certain instances they can help you, but not always. And they need expertise and they do have complications. So think about stents first. Dilated but not obstructed colon. We talked about this. Colonic pseudo-obstruction or chronic inertia. Two totally different items, and we talked why. We explained why. What obstructs the colon? Not usually adhesions, and almost never. I haven't seen a patient with obstructed colon because of adhesions, and usually it's not a hernia. I think in 30 years, I saw one patient with sigmoid obstruction because of left-sided inguinal hernia. One. But what we talked about, these are the usual causes. Cancer, volvulus, diverticular disease, or stricture. In that order, guys. Cancer, volvulus, complicated diverticular disease, and stricture. Remember, sigmoid diverticular disease, not always inflamed or bleed. They do obstruct. Remember that. Our residents forget that all the time. All the time, they forget that complicated sigmoid diverticular disease can obstruct the colon. The most common mechanical cause of large bowel obstruction is colorectal carcinoma, followed by diverticulitis and volvulus. So, guiding statements. Can I have some statements to guide my management here? Statement number 1, always resuscitate the patient in an emergency room. A single stage operation is preferable and can be performed safely without added morbidity. Don't give all these people a colostomy. You can always do a primary anastomosis and we'll see how. Adequate intravenous IV contrast, adequate intravenous access. Okay. Adequate intravenous access with IV fluids is important for resuscitation. Make sure you have this and start that quickly and start it in the emergency room. And this is the X-ray we're gonna get. CT scan is the imaging modality of choice for patients with clinical suspicion of obstruction. Here we go. What the CT scan will tell you, I think we talked about that. Don't give oral contrast, you simply don't need it, and it will only delay you. So you really don't need, you really don't need oral contrast. Rectal contrast. Things about the rectal contrast can tell you, I think we're redundant now. We talked about all this. Is the colon obstructed or dilated? Don't make the mistake again of taking somebody with dilated colon to the OR because she doesn't or he doesn't need to be there. If obstruction, it is complete or partial. And you can see this here. This is a barium enema, but gives you an idea what a complete obstruction would look like. This is probably a volvulus, actually. It's complete obstruction. You can see that. Tapered bird's peak appearance, okay? That's complete obstruction. That should get you out of bed, right? Is the obstruction proximal or distal? The splenic flexure is the dividing thing. So distal to the splenic flexure is distal or left colon. Proximal to the splenic flexure is proximal or right colon. Even more, CT scan can further demonstrate carcinomatosis, liver mets, ascites. It can tell you all this. Excuse me for 1 second. So.
You want me to take the page, Dr. Mostafa?
You are welcome, Mr. Muhammad Usman Fikri.
Assalamu alaikum. It brings joy to my heart to see Professor Rashid, Professor Sulaiman Hussein, and Professor Gamal together teaching in this forum. I'd like to thank the three of them on behalf of the Surgical Club Group. It's a really innovative venture in surgical education and global surgery. All the credit goes to Muhammad Abbas and his colleagues to get this together.
Okay. All right, Muhammad, we're back. So
yeah.
CT scan will further demonstrate liver cancer or metastases or ascites, right? So let me make sure that I didn't mess up my slides here. So it will give me less information. You can actually, if you don't like CT scan or you say you don't have a CT scan, you can get a barium enema, but it'll give you less information. No liver imaging, and you cannot detect ascites. So the bottom line is, this is the bottom line. When a plain film shows dilated colon, you need some kind of rectal contrast study unless you are certain there is perforation or sigmoid volvulus. A really important statement here, guys. So if the plain film shows dilated colon, you definitely need some kind of rectal contrast study, unless you're 100% certain it's sigmoid volvulus or you're certain that the colon is obstructed. So cancer that we talked about, the most common symptom of large bowel obstruction from malignancy is abdominal distension. That's typical. Typical scenario is older patient present with acute malignant large bowel obstruction, often not had a colonoscopy before, like we just talked about. Where is the cancer? Right colon, left colon, lower 2/3 of rectum. What Mazen talked to us about. different story. Right colon, left colon, lower 2/3 of rectum. Remember, guys, it's a different story. Okay. Is the goal palliative? If the goal is palliative, this is easy. You can just divert them, right? You don't really have to do anything. So palliative, you can do a stent, or you can do a colostomy, and you're done with the story. But that's not our problem today. Our problem today is a little bit different, right? So the most compelling indication for stenting is a colorectal if you have cancer and you need palliation only. This allows the patient that you're done, you can get chemotherapy, you don't really have to do anything else. But again, that's not really the classic scenario that we have here. Stents can be okay, again, for palliation, but not really a definitive management. Curative intent is totally different. Curative intent of a resectable lesion is totally different story here. Patients who have a resectable lesion are managed with surgery. Here we need an operation. Now, considerable advancement has taken place in the last few years. In the old days, every single one of these patients had a colostomy, because we were thinking that we cannot do a primary anastomosis unless we need a bowel prep, which is not the case anymore. One operation, single stage, no colostomy, no bowel prep. Does it matter right or left? This is the advancement that we have right now. And to answer you guys for all this, we always thought that right colon can be one operation without a colostomy. It's different now. Left colon also can be one operation without a colostomy. Depending if you have a clean colon, like Mazen said, if the patient can ambulate, if the patient is continent, if you don't have a huge fecal burden, if you have all this, the patient is not sick, the patient is not on presses, if you have all this, absolutely, you can definitely do one stage operation, even in the left colon. So, but again, you have to have the right circumstances. Yes, so the answer is yes for the left colon, as long as here are the conditions. And you have to have all of them, not just one of them. Patient is physiologically stable. Now, and should I resect now and come back later for anastomosis if the patient is sick? The tumor can come out, and remember, that's why I underline this again. Do not do resection for mid and lower third rectum. Big mistake. So when the patient is ill, like trauma, what we're gonna do, we're just gonna go in, resect probably the obstruction, put vacuum assisted closure, vac sponge, and come back later. Right-sided lesion, easy, right? We don't have a problem with that. Most of the time, single operation with resection. Left-sided, in the old days, 2-stage operation, bowel prep, and all this. Nowadays, no. We changed. Nowadays, we try as much as possible to do single-stage procedure, preferable, and has shown to be safe and effective. And again, here is a paper really documenting this. As long as you have the circumstances that we talked about, patient is stable, patient can walk, patient is continent, you have to have all these together in order to be able to do a primary anastomosis. Single stage operation appears to be equally successful on both right and left-sided lesion, okay? Now, if you are a believer in mechanical bowel prep and antibiotic prep, you're not gonna do a single stage operation. And you have the right to say so, fine. But I guess what we're trying to tell you, if you do a primary anastomosis in the left colon in a stable patient who's ambulating, who's young and healthy and all this, you haven't committed such a crime. Because there's a lot of papers out there now saying it's okay to do this. But when I say that to our residents who are sitting for the error boards, I'm not going to tell them this. I'm going to tell them everything I'm saying here, but I'm going to tell them for the oral boards, I think it's much safer to say, I'm not going to do primary anastomosis in the left colon on unprepped colon. I think it's safer in the oral board to still maintain the fact that you need bowel prep for this. The extent of resection that me and Mazen talked about, sigmoid resection for the left side, or total abdominal colectomy with ileorectal anastomosis. And when I asked Mazen about the number of operations that you can potentially perform for left-sided lesion, here they are. You can do 5 different operations for obstructed left colon. You can do a segmental colectomy and anastomosis, sigmoid colectomy, of course. You can do a total abdominal colectomy and anastomosis. You can do segmental colectomy, anastomosis, and protective ileostomy. If you're one of those who believe that I need bowel prep, you can do segmental colectomy and colostomy, the Hartmann's procedure, right? You can do a total abdominal colectomy and an ileostomy. So all these are potentially operations they can perform for an obstructed left-sided colon. Depend on the circumstances, and you can apply, you can pick and choose. Probably the last operation, the total abdominal colectomy and ileostomy, I'll do on a sick patient with perforated cecum, very sick, on presses in the OR. Absolutely. We'll take the entire colon out, do an ileostomy, or not even an ileostomy, I'll just put a vacuum assisted closure, a sponge, we'll call it Abzera here, and come back later on and do an ileostomy. Segmental colectomy and colostomy, if you're believing in bowel prep and you don't want to do a primary anastomosis. If you're still a believer in a bowel prep, but you want to do make your future operation much easier, you don't have to go to the pelvis, do a segmental colectomy, do a primary anastomosis, and do an ileostomy to protect it. So there are options. So segmental resection should be performed unless cancer exists in the proximal bowel. Viability is in question. You should probably do segmental colectomy. I wouldn't do total abdominal colectomy. So some authorities, as we talked about Mazen, that they prefer total abdominal colectomy is the operation of choice. Why do they do this? Because they have some good rationale. Total abdominal colectomy, what's good about it? I don't have to worry about synchronous proximal lesion. So if you're in the oral board and you're saying, I'm going to do total abdominal colectomy, ileorectal anastomosis, I think that's perfectly acceptable, actually. But make sure if you say that you have the right rationale. Why are you doing this, sir? Because I don't have to worry about synchronous lesion in the right colon. Perfect. My patient never had a colonoscopy before. I don't have to worry about these 10 to 20% with another lesion on the right. Another reason, sir, that I'm going to do a total abdominal colectomy with ileorectal anastomosis, I believe that bowel prep, but I don't have to worry about it, and I can do an ileorectal anastomosis and I avoided a stoma for my patient. So, it's really reasonable, and it's a perfect thing to say in the oral board, actually. So subtotal colectomy is the preferred operation, arguing that synchronous tumors are there up to 11% of patients, and on-table lavage, like we see here, it really isn't an easy thing to do. If you try and do that sometimes, it really is very hard, and it's a very messy thing to do, actually. We did that a few times, but it works, but it's extent. Don't do that on a sick patient. In itself, this could take an hour and a half or so, and the patient is exposed to the low temperature in the operating room. On presses, please do not do this on a sick patient in the operating room. Not a good night when you do this on a sick patient, so always remember that. If you're worried about an alternative about bowel prep, just do manual decompression, just evacuate that fecal loading. I think it'll give you just equivalent outcome. So current data do not support the need to remove additional colon without a cause, so always do a segmental resection, unless you're really worried about cecal perforation in these instances. Right, so how about protective loop ileostomy? Yeah, absolutely. If you want to stay in the middle ground, do a primary anastomosis and do a protective loop ileostomy. So here's a nice algorithm we can go by. Chronic obstruction proximal, we're going to do right colectomy. Distal, we can do resection, primary anastomosis, unless the patient is sick. I do something else like Hartmann's, or if I'm a believer in bowel prep, don't do a primary anastomosis. We're going to finish with that. Obstructing rectal cancer, like Mazen mentioned, it's a totally different disease. So here's a handwritten algorithm that I'd like to leave some handwritten things so we can see it. Gives you a little bit of a personal touch to the talk. So obstructing rectal cancer, upper third, treat as sigmoid. That's not a problem. And mid and lower third, do not resect, divert. And how low is the lesion? If the lesion is very low, it's going to need APR, fine, go ahead and do loop sigmoid colostomy. If the lesion is mid-rectum, you're going to need LAR in the future, do a loop ileostomy. Go to neoadjuvant treatment and come back and do definitive cancer operation. All right. Thank you, guys, and we'll take any questions.
Well, thank Prof. I think this is very illuminating. I think there are two messages here. The first is that, as you just mentioned it, whenever you answer a question, you must have a justification. And this is very well put on the left side of the colon. When you do a resection and primary anastomosis, it has to be actually based on 1, 2, 3, 4, as he mentioned it. I think this is very important. The other thing, I think, for the residents, I think we need really to explore this area because CABG is a common operation and spinal fixation, but I don't know whether we really get any colonic pseudo-obstruction or problem. I think this is an area probably for one of the residents to do a thesis because you can really go around and see, because I can't, remember very, very few cases that. And I think the third thing we have already mentioned that as far as the sigmoid volvulus, I think it needs really to be readdressed again because that was, I think, a long time ago. And most of the patients, I think we get, as I said, middle age and young patients coming from the countryside with loaded colon. Few of them actually, probably Mr. Suleiman might probably comment on this, might have these recurrent attacks which you suspect they get distended bowel and they pass motion. They give you in the history. And when you do a peri-MMA, you get this redundant sigmoid colon and do an elective. But these are very few patients who can really come at an early stage and can be diagnosed. Well, thank you, really very illuminating and very educating session.
I would like to, Assalamu alaikum, this is Muhammad Fikri. I'd like to thank Dr. Gamal Mostafa and Dr. Professor Rashidu, Professor Suleiman Hussein for this piece of art, really. I can't speak enough about it. It's piece of art where world-class surgeons come together through virtual platform to work some innovative educational venture. Where Dr. Gamal Mostafa, with his vast and extensive experience teaching our young surgeons in Sudan, Professor Rashid with his very vast experience and linking both the book answer with the practical surgery in tropical surgery in the third world versus surgery in the West. It's just a beautiful piece of art, wallahi. And it's something I think the credit beyond what the professors has offered goes to the young surgeons who arranged this, specifically Muhammad Abbas. When he reached out to me to give a lecture, I thought that why don't you guys do this in a regular basis? And it was a simple idea, but I really never thought that it would grow to this level. But it's I find it hard to express it through words. Like, and it brings joy to my heart to see this happening. And thank you very much for the support and for the teaching.
Yeah, thank you so much, Muhammad. And I'm sure you picked up on a few things here about colonic obstruction, I'm sure.
Yeah, absolutely. طبعا Dr. Gamal Mostafa is the chief of surgery at the VA. I'm a section chief of vascular surgery at the VA, so I work with Dr. Mostafa at regular basis. Also, Dr. Mostafa covers trauma and acute surgery at the University of Toledo Medical Center, where that's my main hospital. Professor Rashid is a mentor of mine, and I worked in his unit as a houseman. And when I joined the Department of Surgery, I was working under his mentorship. Professor Sulaiman Hussein, he's also a mentor of mine. When I first took a job as a teaching assistant at the Department of Surgery, Professor Sulaiman was acting chief of the head of the Department of Surgery. And I remember vividly sitting in front of him in the office and you know, for the first meeting as a new hire in the department, and he was telling me that we need new blood in vascular surgery. At that time, I did not know what vascular surgery was, but time goes by and I did vascular surgery, and hopefully we'll go back and join the staff, inshallah, at one point.
Now, the most important thing, Muhammad, you need to get us to visit, you know?
You have the top authority of surgery in Sudan right here, Dr. Jamal. It's Professor Rashid Sulaiman Hussein. They are as high as it can get in Sudan.
Yes, I think we'll look into this. I think that will be really a great prestige for us to come as an examiner sometime in our medical school or probably the postgraduates. I think that can very well be arranged. Well, Muhammad, thanks really. I'm very impressed.
It will be my honor, actually. Honestly, it will be my honor.
Yeah. Yeah, I think we can bring it to a higher level of probably more, I mean, practical visits and contacts between our residents and the USA there. I think things might probably improve a lot. I mean, in the coming few months, I think things are going in the right direction. And the relationship between the United States and Sudan probably is growing every time. And we hope to come to its ultimate junction of lifting the sanctions and exchanging, because we used to have this previously, I mean, the Fogarty and the Fulbright scheme between the University of Khartoum and the United States. But I think we'll revive this, hopefully.
Inshallah, we will do that. I think, so we have access to two universities here, University of Toledo and Wayne State University, between Toledo, Ohio, and Wayne State in Michigan. I think we should continue the educational mission, and I think we should grow into research, where we do collaborative research projects together, and maybe exchange missions, where we bring people from Sudan, get some training here from the younger residents, and as soon as they graduate, and also send some of our surgeons here to get exposed to different type of surgery back home in Sudan, and help, especially for specialties like vascular surgery and other rare subspecialties. I truly believe that we can do great things together in this regard, certainly in research.
Yeah, and inshallah, we'll do everything we can to integrate and work together, inshallah.
Inshallah. Thank you very much, everybody.
Yeah, thank you. Thank you. All right, thanks everybody, and we'll see you soon, guys, with a different session. And Mazen, you did really well here. I